fall. We're we're noticing a little change in the weather. It's starting to cool down a little bit. It's gorgeous outside. So we're launching into our fall season, and that's really exciting. At least it is for me. Maybe not for you, but it is for me. Um, the code word for today is health. I will put that in the chat so that you have that. So make sure you write it down or, somehow remember that. I will also put Gabby's email in there so that if you lose connection, she's the one that you are going to email that word to and she'll get you readmitted. Make sure that you're letting her know if your sign-in name, if your screen name on here is not your actual name, please let her know what it is so she can recognize you when you're trying to get in and she can get you in. And oh, somebody just barely joined. So we just announced our code word. It's health. I will put that in the chat. Also, remember the evals at the end. There is a message in the chat that will give you the link for your evaluation. So make sure that you watch for that, just those last few minutes of the training, and grab that link so that you can fill that out and get your CEUs. That will need to be done by the end of the week, by Friday, so that then you don't miss out on that link. After the Friday, the link no longer works. So if you have any issues at all, please email Gabby so that she can work that out and get that link to you. After that, it's a little harder. You got to give us a little more information. So I want to make sure that you're getting those CEUs. Also, for today, for this training, for your questions, Ashley has requested that she kind of do questions at, as a chunk, unless it's something that really needs to be answered right then. So it's a lot easier if you just put your questions in the Q&A, so I don't have to try to keep track of them in the chat. If you put them in the Q&A, that little box at the bottom of the screen, then it's there. We can always go to it, read those questions, and get those answered. So let's use that today. It would be a little more organized for us to make sure that we're getting those answered. I appreciate that. Okay, let's get going. I am so excited to introduce our presenter. We've been back and forth for months now, and it's just been so much fun to talk about this topic. And it's something that I was very unaware of, and I think a lot of us are. And so that's why it's so important that we be talking about it today. I want to introduce you to Ashley Dean. She is an LCSW and works in the social work field. She has an interdisciplinary certificate in women's health, and she specializes in medical social work. She especially works with people with chronic illness, and especially POTS. And so she's going to be teaching us about that today. And so I'm going to turn the time over to Ashley, and we're so excited that you can be here. Thank you.
Yeah, thank you for having me. I am really excited to share all of this information. I might have gotten carried away. So if we don't make it through all of the slides, they're all in the presentation and Kelly will be sending this out. And we are going to go kind of fast. Um, so the topic is chronic illness, what mental health providers need to know. I thought maybe we should change it to chronic illness, everything mental health providers need to know. Just kidding, because it's so long. Um, but the objectives today exist because we get so many clients that say that the doctor said everything looks great. Have you thought about seeing a therapist? So, why does this happen? There's bias, there's women health disparities, and ableism that leads to mental health referrals and gaslighting. I'm going to do an overview of POTS, MECSF, long COVID, dysautonomia, hypermobility spectrum disorders, mast cell activation syndrome, and other comorbidities. I'm going to talk about the intersection of chronic illness, pain, and PTSD and therapy modalities, and you will get lots of resources. Kelly and I talked about this. My life changed in about 2013. I was running Ragnar and training to run Ragnar, and my left leg started to swell. So I tried to share things about my life to help you understand who I am if you would have gotten a client like me. And I want you to think about, if you were my therapist, what would you do? What would you say? Um, I'm a little bit potsy right now. My watch is red. That's like the worst thing. Potsy means that you're having symptoms of POTS, which include brain fog, shakiness, chest pressure. I'm fine. It's just that I have POTS, but I might be more shaky or have more brain fog. So I wrote these down so I could read them because I do have POTS. So from 2000 to 2003, I was a wildland firefighter and a college student. My adolescence and childhood were not significantly impacted by illness. I had weird flushing when stressed. I was diagnosed with IBS at 19. I had painful periods, PMDD, yearly sinus infections starting at about 16, nothing limiting, and a few weird injuries. I was a high school valedictorian, I was a scholarship student, and I experienced seasonal depression. And I would say that I overcame social anxiety. In 2003 to 2008, I was able to backcountry ski. That's where you hike up the mountain and ski down on telemark skis, which is a different way of skiing where your heels aren't connected. Um, I was a full time college student and I worked part time. I got married, I had a baby, I graduated from college, I worked 32 hours a week. I was an active mom working during the day and doing home improvement or outdoor activities in the evening. In 2008 to 2013, I was a full time teacher, online student. I had my second baby. And while I was pregnant, I had to have my gallbladder out. And I just started having hip pain while I was pregnant. Everything went away after I had my daughter, except for when she was about 6 months old. I needed to have a hernia surgery. And then in 2013, I was an able bodied, active single mom. I could take care of my house, I could take care of my kids, I could exercise after school. I was a teacher, um, no issues. So I was training to run Ragnar and I got lower left pain and swelling, and I had to wear a walking boot for about 6 weeks. I thought that I just had a running injury. I thought my life would get better after that. In 2013 to 2015, doctors couldn't find a reason for the swelling and pain in my leg, and I had to stop playing. I played like adult volleyball and I couldn't run Ragnar. During this time, I remarried, moved, worked part time as a teacher, and cared for 4 children. I have 2 kids, and my husband has 2 kids. And the swelling in my calf actually decided to move up my leg. And I had severe sciatica, making it so I couldn't sit. I kind of felt like I had a curling iron burn on my butt, or like, yeah, pretty much. And this led to limited mobility. I remember my husband ran a half marathon and I went to like meet him at the finish line, but I didn't make it. And I was like, oh my gosh, you told me to park in the wrong place. And he's like, I just ran a marathon, Ashley. So, doctors, when I would go to them, were like, there's nothing wrong with your back. You don't have sciatica. And I'm like, well, I do. And so they had no idea what was wrong with me. In 2015 to 2016, I was diagnosed with fibromyalgia and chronic fatigue. Multiple providers recommended therapy to resolve trauma. My specific left sided pain and obvious swelling didn't matter. I thought that I just had fibromyalgia and chronic fatigue. I thought that I needed to work on my trauma. My primary care doctor she was like, just go to one more doctor. And he actually took x rays of my hip and sent me to a hip specialist that had completed a fellowship in Texas with like the national leading expert on sciatica related to the female hip. Um, my hip issue was specifically related to being an active woman, and the medical field only recently started learning about and treating women's hip injuries. And when I had the surgery, strangely enough, I had vascular collaterals that made it so my hip surgery had to be open. So I had like three little scars, but then I have one like this big because it had to be open because they could not see with the camera. The day after surgery, I had to stay in the hospital overnight after that, but then I went home and I told my husband, I'm like, I think I'm gonna pass out. And he's like, no, you're fine. Just sit down. And I was sitting on the stool and he got me. And that was the first time I passed out. I went to the emergency room. They told me that it was just because I was dehydrated from surgery. But I just kept trying to recover. I was teaching at a group home for girls. Maybe you all have heard about it, Aspire. And I just couldn't stand up and talk anymore. I had no idea why, but I had to quit before the end of the year. I think I quit teaching in about February or March because I I couldn't think standing up, and it's you just don't know what's going on with you when that's happening. So I decided that I would apply for grad school and that I needed to have a job where I could sit down. So I had no idea that I had pop. Um, okay, what is it doing? Okay, so I have to move where the people are. Okay, so I knew about the chronic pain cycle. Fear, depression, chronic pain, tense muscles, stress, fatigue. I thought, like, I don't know, maybe that's what's wrong with me. This has been very difficult. Um, I did have suicidal ideation before I had hip surgery. I did have to see a licensed PhD psychologist to be evaluated to see if I could even have the hip surgery. And I still had to fight my insurance to pay for it. They did, but I guess at the time in 2017, it was very common for surgeries not to be covered in female hips. Um, then you have like society, and everyone has something to say about chronic illness. It's not so bad. You have a great life. He man, the best yoga is medicine and being in the outdoors. Only Jesus can cure you. I've seen this in chronic illness and in eating disorders. I was very surprised working at Center for Change when people would come in extremely underweight and their parents had told them to read the scriptures, which that helps if you're a spiritual person, but not if you need medical care. I asked my supervisor what I was supposed to say when people thought that, and she told me to tell them that that's why God made therapists. So I think that's a good answer. A lot of people think nothing is wrong with you. It's all in your head. Stop whining, get over it. Why do you talk about your chronic illness so much? Like, that's all you focus on. That's why you're sick. I've heard every single one of these things. Um, I have an amazing product for you. Have you tried this diet? And then people saying, like, yeah, I get pretty tired after work too. They don't really get it. And then thinking, like, I was a very active person who had a lot of ideas and ways to live my life. And I thought, like, I can do this, I can get better. Um, that did not help. And then we have this going on in society and culture. I'm just going to play this.
80% of autoimmune disease, which are diseases where the immune system attacks the body that it's supposed to protect, 80% of them happen to women. Why? I knew people before they got sick, and I knew them in the context of their families of origin. And these people had four significant characteristics. One is they tended to put other people's emotional needs ahead of their own. Number two, they tended to identify with duty, role, and responsibility rather than the needs of the self. Number three, they tended to be very nice, which means they repressed healthy anger. And number four, these people tended to believe that they're responsible for how other people feel. Why is it women? Because who in this culture is programmed to always looking after everybody else's emotional needs, taking everybody's stresses, identify with their duties and their role, not be angry in a healthy way, and to take responsibility for other people's feelings? It's women. It's not a gender issue, it's a cultural issue.
When I saw that video, I got pretty mad. It is definitely a gender issue and a cultural issue. It is far more complicated than that. And I am not one to like keep my feelings to myself really at all. So doesn't fit for me. And then I thought, is it trauma? I do have trauma. And if we look at the physical symptoms of trauma, it's chronic fatigue, chronic pain, being easily startled, the emotional symptoms, feelings of shame and guilt, agitation, edginess, trouble regulating emotions. When your nervous system isn't regulated and you have hot symptoms, it's not because of what's going on in here. It's because your body can't regulate its blood pressure or your heart rate. And then the psychological symptoms, anxiety disorders, depression, nightmares. I don't have nightmares, but after I started getting sick, I definitely had more anxiety than I'd ever had. I was definitely more depressed than I'd ever been. And depression does run in my family. So there is a connection between PTSD and pain. 80% of people with PTSD report chronic pain. And patients with PTSD and pain have greater opioid use, more severe depression, anxiety, and more disability than patients with only one condition, either pain or PTSD. They are more likely to engage in suicidal behaviors than patients with just chronic pain. So PTSD and trauma are something definitely that are important to think about, but they are not the only answer. And then there's a lot of like medical and self and society gaslighting going on. We talked about society, but in your mind, you're thinking like, is it all in my head? It's my fault that I'm sick because I eat too many chips, or I had a Coke, or I didn't exercise, or I'm not sleeping well enough. And then I've been told my entire life that I'm too sensitive. So maybe it's because I'm too sensitive. Lots of things. And you have other people saying this to you too. It's not just in here. And I really do want to point out that this is gaslighting. I don't think that providers are trying to lie to us when we go to the doctor and they don't help us, but they are convincing us that a problem isn't a problem and trying to tell us to not listen to our bodies. They are making us question reality. They are telling us that we are imagining things. And there is proof, a lot of proof, that this is not anxiety, depression, or PTSD. I have a website. It is called Believe Pain because of this. A survey of 2,000 Americans reveals that respondents have been told by doctors that 57% of their symptoms are simply due to stress or anxiety, and 54% have been told that they need to lose or gain weight in order to get better. 72% of millennial females and 61% of millennial males report feeling dismissed or ignored by doctors. So this is not just my story. I am not the only one going around trying to figure out what in the world is going on with me. Lots of people are doing that. Lots of people are going to therapy saying, my doctor told me it's all in my head. And as a therapist, like, you can't fix all of these things. You need to understand them. Um, so in 2017 to 2019, I completed grad school and I was diagnosed with POTS in the emergency room the last month of grad school. About 2% of people get diagnosed with POTS in the emergency room. My ability continued to be impacted by fatigue, left sided swelling. I struggled to work more than 15 hours a week, to complete household tasks, and to attend family events. So it took me longer to get my L. I'm not able to work at a nonprofit to pay off my student loans like I thought I would be. And the doctor that I saw for my pot said, there's nothing really you can do, just drink salt. So, okay. Um, so I was researching POTS and it led to questions about pelvic congestion syndrome, May-Thurner syndrome, and Nutcracker syndrome. I like read on one doctor's website who sees a lot of people with POTS that there's a comorbidity between POTS and pelvic congestion syndrome. Pelvic congestion syndrome is varicose veins around your uterus and ovaries. And mine, I I did have that. So like if you have pelvic pain, if you have POTS, pain with sex, um, pelvic congestion syndrome is often marked on MRIs, but people think there's nothing you could do about it. Insurance actually pays for men to get pelvic congestion syndrome treated, which is varicose veins around their testes. Um, but they do not pay for women to have pelvic congestion syndrome treated. Um, so I went to a doctor who I thought was pretty good. Um, she was checking me for May-Thurner syndrome and Nutcracker syndrome. I had a hysterectomy with my left ovary removed to treat the pelvic congestion syndrome because I had a period every other week and had to have an IUD. My insurance was willing to pay for that. So the doctor did what is called a venogram, and she gave me a stent for May-Thurner syndrome, which is a compression of your left iliac vein. And she said that I did not have Nutcracker syndrome. So all of a sudden, I had like left my swelling just kept going up my body. Like my right breast was swollen, my left pupil was bigger. He had to check me for all of these things, like cancer, even to see why my left pupil was all of a sudden bigger. I was really swollen. I was really sick. I think you can see in some of these pictures, like this is when I went to Germany to see a specialist to get diagnosed. And this is after my Nutcracker syndrome surgery. So you can tell there's a big difference in like the swelling. I think I lost 15 pounds just in swelling after having that treatment. But this doctor said, you don't have anything wrong with you, Ashley. You need to stop going to the doctor. I'm a doctor and I know. So I went to Hawaii. I kind of felt like I was going to die. I did not know what was wrong with me, and weird things were happening to my body. So I'm like, I've never been to Hawaii. I really want to go before I die. Let's go. So that's me surfing. I people with POTS feel better at sea level. So I had a really fun trip. So in February 2020, I knew that there was this vascular compression specialist in Germany, and I wanted to go there to get treatment. My husband used to be Mormon, and he actually went on a mission in Germany. And we have friends in Leipzig where this doctor was. So I went there, and he told me that I do have Nutcracker syndrome and that I did have MALS, which is median arcuate ligament syndrome. It is also related to POTS. Some people who get Nutcracker syndrome and MALS fixed, like early on, their POTS goes away and they feel better. I haven't been that lucky. So to treat Nutcracker syndrome, I had a left kidney auto transplant, which means they moved my left kidney to my right side. And that resolved my swelling, left-sided migraines, left-sided pain. All of a sudden, both sides of my body were the same size. And let's see, it's been 7 years since I've had left-sided swelling at this point in time. Um, I did feel a lot better. I was able to work more like 15 to 20 hours a week, but I really thought that after I had my kidney moved, my life would significantly improve. I found out that I have a hypermobility spectrum disorder, and that is one of the underlying causes of these issues. In 2023, I got a little bit potsy skiing, and I um, like fell over. I had a helmet on, but it made any kind of like CSF leak that I had worse. And my physical therapist thought that I had a CSF leak, but I couldn't get into any doctors because they didn't think that my symptoms were serious enough. And I went to the CSF leak doctor in Utah, and he says, "What makes you want another chronic condition?" And this one doesn't really have answers either. I'm like, I love coming to the doctor. It just makes me feel like the center of attention, and I need attention. Just kidding. I do not say that. Sometimes I feel like saying that. So I ended up going to Colorado to get my CSF leak sealed. I had a complete remission of symptoms, and I hardly ever get migraines, and I have a much easier time being upright. Here's a video of similar stories.
It's very presumptuous to say, I can't see what is causing your problem, so ergo it doesn't exist.
We're taught in medical school when we don't understand something that by default it's psychological.
Many of them are thought to have normal physical examinations. So the assumption is that they're making stuff up. But if you do a careful physical examination and you measure their heart rate and blood pressure response to standing, they're not normal at all.
The children's hospitals, it was awful. I've never been treated so poorly in my life. They always would say, Hannah, you know your mind is stronger than your body. And if you really wanted to get better, you just have to put your mind to it.
When the takeaway is it's all in your head, just try harder. These are people who are trying. So we've broken a therapeutic alliance, and there's nothing good that comes out of that situation.
Once you have been told you're crazy enough, I think you slowly start to believe it because nobody's validating your feelings.
When they feel dismiss, what I commonly see is that they give up because they feel like nobody's going to help them.
I'm just worn out from all this pain not being better. I just really want it to be over. It feels like the end, like the end of the story and you're done.
These kids are not trying to fool me. They're not trying to make excuses. There's a lot that's wrong with these folks. It's not a psychosomatic disorder.
We need to be okay as medical professionals saying, I don't know. And let's find ways to help you function better.
History will judge us. Just like we judge the people from 50 years ago, like the same stuff they did and they believed, it's going to come full circle.
This is actually a Utah film producer who has Nutcracker syndrome and POTS. And the doctor at the end was Dr. Colby. A lot of these patients, maybe all of them, are from Utah. So this is about spreading awareness because of delayed diagnosis. 60% of POTS patients are told it's all in their head before diagnosis. 60%. POTS patients see an average of 7 providers and wait an average of 4 years for diagnosis. 26% of patients with chronic fatigue syndrome wait 2 to 5 years for an accurate diagnosis. 19% wait more than 5 years. There's an average of 22.1 year delay in diagnosis for hypermobile Ehlers-Danlos syndrome, and misdiagnosis is common. 60% of people are misdiagnosed with fibromyalgia, anxiety, or other labels. And this statistic is from the Norris Lab. And the Norris Lab is a place where scientists with hypermobility disorders work on figuring out what causes hypermobility. Then we have women's health. When I went to grad school and I found out all of the things about women's health, I couldn't believe it. Before 1993, women were rarely included in clinical trials. That year, Congress passed a law requiring women be included in NIH trials. Women experience adverse side effects from medication twice as frequently as men due to lack of research on female bodies. Women are 29% more likely to lose a hip joint replacement, possibly due to lack of testing and anatomical differences between male and female hip joints, similar to the problem that I had. In 1999, the medical field recognized that heart disease affects women differently than men. 1999, heart disease is a leading cause of death in men and women. So in 2022, a Harvard Medical School study found that women were still underrepresented in clinical trials for leading diseases that impact their experience. There is a lack of research, the lack of research could cause healthcare disparities because biological sex can play a role in physiological, metabolic, hormonal, and even cellular differences that can influence how diseases present. So it is not because of the way we handle our emotions. I don't know a whole lot of men that are like freely expressing themselves and not holding it in. So it's complicated. There are also gaps in funding for dysautonomia. This is just like the projects funded and the amount of money. There's multiple examples of this where like Parkinson's is receiving billions of dollars. Rheumatoid arthritis is 4.7 billion, and it affects 1 in 450 people. And dysautonomia with POTS is 1 in 100 people and 305 million and 525 projects versus 13,979. So it is improving, especially since COVID, but there needs to be more research. So there is gender bias in pain treatment. Women are twice as likely as men to die in the year following a heart attack. It takes 4 years longer for women to be diagnosed with a chronic medical illness than men. It takes 2 years longer for women to receive a cancer diagnosis than men. Women are more likely to be given a sedative than medicine to manage their pain. In the POTS cast, this podcast about POTS, there is a history professor who has what she thinks is severe anxiety, and her psychiatrist is giving her loads of Xanax to deal with it. So that does not fix POTS. She was later diagnosed with POTS, and that really helped her manage her anxiety. So mental health matters. Individuals with multiple physical health conditions tend to have a lower quality of life and a higher likelihood of mental health disorder. That means that we're seeing more people with these problems. Qualitative studies show negative bias of healthcare providers towards patients with serious mental health disorders and medical comorbidities, probably affecting their access to care and the type of care they receive. All of those things going on in society and culture also affect us as providers. And honestly, like I had no idea that I could be this sick or this disabled. But now I have a much better understanding of that. And it is definitely real and definitely debilitating. I went to a therapist when I first got sick, and I was like, I can't run, I can't ski, I can't do my laundry, I can't do anything. And she's like, well, can you still go to Relief Society? And I'm like, I've never been Mormon. So that was even like less helpful. Then invisible illness. So it means that you can't see it. A sunflower is a symbol for invisible illness. You can get like lanyards to wear that show you have an invisible illness, especially if you go to the airport. I've heard that you can just ask about them at disability services at the Salt Lake City airport. These are also dynamic disabilities, meaning that one day you can do a lot of things and the next you can't. So it's very confusing for people to understand because you don't look sick. Globally, about 1 in 6 people have a disability. 80% of those are invisible. So, what is ableism? I'm just gonna play this video.
What is ableism? Ableism at its core is the discrimination and prejudice against disabled people, rooted in the belief that non-disabled people are superior to disabled ones. It treats people with disabilities as if they are invisible, disposable, and less than humans, or taken for granted the able-bodiedness of humanity. It can be systemic, meaning that it's baked into the systems of our society. It can be interpersonal, meaning between 2 or more people, and it can be internalized, so the faults of a disabled person.
Okay, so I found a study that said ableism was cited as a major barrier to mental health care for people with disabilities. That was in 2024. I don't know if you've ever heard about the Harvard implicit bias test, but we took them in grad school. You can take one for weight bias to see if you're racist, sexist. So they're interesting. But one of the problems that a lot of people with chronic illness and pain have is internalized ableism, which is shame, self-doubt, and insecurity that's perpetuated by feeling less than due to ability. So, and you do, especially because if you used to be able to do things and now you can't, and you look fine. So, weight barriers also impact health. It says research shows that when seeing people with obesity, healthcare professionals spend less time, perform fewer interventions, attribute unrelated problems to weight. 69% of adult women said physicians were a source of stigma. I've heard that physicians are very much like able-bodied people most of the time because medical school is so difficult. They exercise, different things like that. So they don't really understand what it's like to have problems. And weight barriers are not because people are lazy, but they have multiple complications. Identity. So respondents say medical gaslighting was more severe because of their gender, race, ethnicity, identity, or sexual orientation. I remember in grad school, there was a 2017 study book of medical school textbooks, and the only place women anatomically were shown in the textbook is in this study of several textbooks was in the part talking about reproduction. Then there are racial barriers to health. So I just thought this was interesting. It says that 93% of people with POTS are white, 1% Black. So just not very many minorities in there. And you always hear people with POTS have type A personalities. They're kind of pushy, they're perfectionistic. And I would argue that the people with POTS that have type A personalities that are perfectionistic are the only ones being diagnosed. They're the only ones pushing for care. Over on this study, it says that Black individuals struggle with higher prevalence of chronic conditions, and they have higher rates of undiagnosed chronic conditions. There's also cost, social, cultural, and location barriers. Like, does your insurance pay for coverage? Is the provider in your network? Where are you located? Are you in a rural area? Are you in an urban area? How many providers exist? I'm not positive, but I think in Utah, there are only like less than 5 providers certified in dysautonomia medicine. The cost, many of these providers only accept cash, especially if they're highly specialized, and culture. In grad school, we read a book about Hmong people, and there was a little girl that needed seizure treatment, and she was taken away from her parents because they didn't believe in medical care, and she was having severe seizures. Um, and that was their culture. And so the doctors had to learn to work with them. Some people don't believe in healthcare. Some people think medicine is evil or it's bad to take medicine. And like, what have you learned about that your whole life that's gonna like affect the way that you deal with your illness? How do your parents act about illness? Um, so this again is my diagnosis timeline. In 1981 to 2013, I was pretty normal, had a pretty what I thought was normal health history. In 2013, I started searching for answers. This is my family then. My daughter was 6. In 2021, I did find answers, but like my kids are grown up. It would have been really nice to have been diagnosed and to get treatment while my kids were growing up, to know what was wrong with me instead of to just struggle. So again, it is not just me. 92% of people with POTS are female, and 48% were misdiagnosed with a psychological or psychiatric disorder. So, yeah. Let's see, these are comorbidities of POTS. So you might see people that have fibromyalgia, asthma, chronic fatigue syndrome, irritable bowel syndrome, migraines, celiac disease, Hashimoto's. People know what those are more: lupus, rheumatoid arthritis, diabetes, endometriosis, MS, Crohn's, PCOS, ADHD, autism. If you see people with these conditions that have symptoms of POTS, and we'll go over those, they should get checked. They're probably gaslighting themselves and saying, I need to try harder. There's nothing wrong with me. I'm just anxious. So this one says 75% of people were misdiagnosed prior to a POTS diagnosis. They saw 7 physicians on average and had 9 trips to the emergency room before diagnosis. Here is a video about POTS and what it is.
POTS, postural orthostatic tachycardia syndrome. POTS is a syndrome that really has 2 criteria, but a lot of associated features. People with POTS have orthostatic intolerance, that is, they don't tolerate standing up, and they have an exaggerated orthostatic tachycardic response. Their heart rate goes up more than it should when they stand up.
When you stand and gravity is displacing blood downward, your brain senses that and makes your heart beat faster, makes it beat more forcibly, and tells the blood vessels in the lower half of the body to become 3 times tighter than what they were before. That tightening pushes blood upwards towards the brain. And in POTS, they're unable to either make or maintain that tightening of blood vessels. And so blood is pulled by gravity downward. The brain, trying to compensate, will then tell the heart to beat harder and faster. And frequently it compensates enough to prevent the person from losing consciousness, but nonetheless is unable to maintain the same levels of perfusion or blood flow to the brain and organs that were previously present.
The problem with POTS is that it is a syndrome, meaning that it encompasses different symptoms. And people do not only complain of their heart racing, but they can complain of a zillion other things.
Shortness of breath, tightness of chest,
Lightheadedness,
fibromyalgia, dizziness, malnutrition, brain fog,
stomach problems,
like sensitivity, sound sensitivity, GI tract shut down,
Headaches, random body pain, sometimes everywhere hurts, fainting, heat intolerance,
blood pooling,
irritable bowel syndrome,
new onset allergies,
fatigue,
tingling. There's about 100.
As you see, it's almost every organ of the body that is affected by this constellation of symptoms. POTS is not an isolated syndrome. it is part of a continuum, of a spectrum of conditions that range from very mild to very severe. And the common link is the autonomic nervous system. So for this reason, we put POTS as one of the major manifestations of autonomic dysfunction, or what we also call dysautonomia.
Although originally we only had a very simple set of criteria to diagnose it, now we realize that comes with a whole package, and most patients have the whole package.
It gets treated in a variety of ways. A lot of us as physicians have our own individualized approaches. I try and look at the most important factor contributing to that person's POT.
Just because someone doesn't look sick doesn't mean they aren't sick. A lot of the patients actually look like young, healthy women. You know, I think if someone was missing a leg, I don't think anyone would question that something's happened and probably have more empathy. I think that sometimes is tougher for patients with POTS because they don't visibly look sick.
How many people have POTS? In all our experiences here, we all can say that we are overwhelmed with patients who have this condition.
We started to recognize the first cases of POTS around 19. Of course, at that time, a lot of doctors thought this doesn't exist, but as the time went on, people realized, no, this is real, and there's diagnosis for it, and now it's undeniable. We have major centers involved, major university programs that are really in the front lines of research.
Okay, so I just wanted to mention that POTS is part of dysautonomia. It's like an umbrella. Dysautonomia is an umbrella term that has POTS and orthostatic hypotension and other autonomic disorders under it. The ones you'll probably see the most are orthostatic hypotension, which means your blood pressure drops, but your heart rate doesn't go up enough to compensate. And inappropriate sinus tachycardia. People may be diagnosed with those things. So to get diagnosed with POTS, your provider might order blood tests to check for like nutritional deficiencies. They'll do a physical exam, and they need to order a tilt table test. In Utah, the U of U is the only place that does full testing, and there's a 2-year wait. And there's also a lack of knowledgeable providers who actually take insurance. There's lots of neat providers that you can see if you can pay cash. Where to get a tilt table test done sooner. So Dr. Toby Paulson, Brad Pontius, Kelsey Bettis at Revere Health could help you get a tilt table test sooner. I would stay on the U of U's waiting list because they check like your blood levels and different things like that. But it's important to get a diagnosis because then you can start managing it. And when you start managing it, your life improves. You can get a primary care referral to Mohammed Tahir. He is an American Fork, Orem, and maybe somewhere else, but that's where I had my daughter's tilt table test done, and my primary care referred me. You can also go and ask in local Facebook groups, which I'll share, about like, who did your tilt table test? Who did you see? And people will help you find doctors. You can also do home testing for POTS. It's called the Poor Man's Tilt Table and NASA Lean Test. And there are instructions in there to do that. There are 3 subtypes of POTS. I don't think it is really important for you to know. A lot of people with POTS don't understand this. But these are examples of blood pooling, kind of like what your feet and legs look like after you get out of the shower. This is maybe what they look like if you've been sitting. and all of a sudden your feet are purple. And I don't know if you can see, but like the blotchiness of the hands, I could probably show you mine. They probably look like that. So there's a big impact on work. 41% had financial difficulties, 37% had to stop working, 28% had to reduce work hours, and 25% had to change careers. I showed my husband this and he's like, "You're a statistic." I'm like, "Oh, fun." um, Kids under 18 years have been unable to attend school for more than 3 months. That's kind of what happened to my daughter. And 16% are now permanently unable to attend school. It definitely has an impact on mobility. 23% of people with POTS use wheelchairs, 11% are not allowed to drive, 5% are bedbound, 7% have no impact on mobility, and 54% have other mobility restrictions. 93% of people reported that their mobility was impacted. So I have a POTS group, and I had a person with POTS in there that thought that she was trying harder than other people with POTS because she was more able-bodied. And that is absolutely not true. There is a spectrum of people with POTS. Some people are extremely disabled, especially like depending on how long they were in bed and sick before they got care. Other people aren't as disabled by POTS. Like Katie Ledecky is an Olympic swimmer with POTS. I was like, oh, she's amazing. How does she swim with POTS? My husband's like, Ashley, she has a whole team of trainers and they knew exactly what it was when she had it. You know, very different story than waiting 7 years. 66% of people were doing regular aerobic exercise and only 25% can do it now. POTS versus anxiety. This is a study that says that excessive heart rate to orthostatic stress is not anxiety. There's several studies and letters that have been written in medical journals about chronic fatigue, dysautonomia, POTS that are like, this is real. It's not psychological. Please believe these patients. I used to work at a hospital and they said that it takes 10 years for what's in medical research to get into medical practice. There's common psychosomatic mislabeling of POTS, as we've talked about. So MCAS, GI issues, and pain lead to worse symptoms and worse mental health. And this is a chart of anxiety. And I put squares around all of the POTS symptoms. So you can tell why people think that POTS is anxiety. It's very similar. This is another one. I circled all of the POTS symptoms that are also on the anxiety chart. So only 1, 2, 3, 4, 5, 6 things that aren't the same as anxiety. This chart was really interesting for me to see as a POTS patient. I'll be having conversations with people and I'm like, I just need to sit down. I can't think. I cannot think and stand up. But this is what's going on. My brain is not getting blood, so I can't think. When I'm sitting down, it's only getting this much blood. So blood flow to the brain causes all sorts of problems. Doc Snipes, I posted her YouTube video in the link. Her daughter has POTS, and I think she's a psychologist, and she talks a lot about POTS. She says it's 4 times harder to stand up with POTS. And a misconception about POTS is that you have to pass out to have POTS. That's not true. And like really only 20 to 30% of people do pass out. So this is our nervous system. It is in homeostasis. And so if your body is in homeostasis, everything is working. Your autonomic nervous system, which controls everything that you don't have to think about, is not working. So if I put a tree here because I think if you were a tree, trees do what trees are supposed to do. And if someone took away like all of the branches on a tree and the tree or sprayed it with pesticides, the tree wouldn't be able to be a tree. And you're not really able to be a human if your autonomic nervous system isn't working properly. It, it's like you're constantly dealing with these problems. And nobody says to the tree, well, try harder. It's your fault that you have a disease. Um, so it's very different to be a person with dysfunction. And this is what happens when your body is in sympathetic overdrive. Also, what happens when you have trauma or chronic trauma. So that's why it's important to make that distinction. Yeah, so treatment basics, I kind of talked about that in the movie. Um, POTS management, these are the best POTS management tips. This one is tilting the head of your bed. People are always like, that will not help. That is weird. I'm not doing that. But when you do it, you can't really tell. And when I did that, I could get out of bed in the morning more easily. People with POTS have a hard time getting out of bed in the morning. And they say that if you drink 16 ounces of water quickly before getting out of bed, it can help improve your blood volume and reduce orthostatic symptoms while you're standing. Um, these kinds of exercise are better for people with POTS, but if you have POTS and chronic fatigue syndrome, which most people do, you'll go backwards if you overdo it. And if you go backwards and get worse, you could stay worse. You may not recover. So pediatric and teen populations, 75% of adolescents with dysautonomia report some type of mental health challenge. And so you're going to see those kids. Moms misdiagnosed as Munchausen by proxy or fictitious disorder. Take Care of Maya is a very sad documentary about a girl with chronic regional pain syndrome. And then there's another documentary called Complicated that is made by the same filmmaker. And it shows kids with hypermobility and parents being accused of that. And so these problems are real. It is very rare for someone to actually have Munchausen by proxy or fictitious disorder. It is more rare than hypermobility and the complications that go with it. This is just a podcast that's supposed to be really good about pediatric dysautonomia, and CHIP, which is creative healing for youth in pain. So unfortunately, my daughter is related to me and she got sick. She couldn't go to school. When she did go to school, she was coming home from school. It was really weird to be her mom because, like, I know what POTS is. I can see the signs. She was really tired. She had headaches all the time. She was always sitting with her feet up. She was hanging out with her friends, laying down in bed. And I'm like, Ellie, you've got to go to the doctor. And she's like, no, I don't, Mom. And I'm like, yeah, you're going to the doctor. So we went to the doctor and we said we were going for headaches and fatigue. And the pediatrician said, people with POTS don't get migraines. And I'm like, they do. I have POTS and I know they get migraines. No, they don't. Okay, cool, thanks. We went to a primary children's hospital pediatric neurologist. And like, this is what I help people do for a living, is like help people get POTS treatment. So it was really sad to know that this is how it went with my daughter. I'm from Idaho. I've always heard really good things about primary and children's hospital. I didn't even look at the provider review. He has very poor reviews. But we walked in and he didn't really ask my daughter any questions. He said, it's anxiety. She's a sophomore in a high school. It's a bigger school. It'll be gone in the fall. Come see me next year if it's not. He said, I see this all the time in teen girls. He told her to exercise for 30 minutes a day, which would have greatly harmed her because of her chronic fatigue. And she already had an orthostatic hypotension diagnosis. He told me that he would not refer her for autonomic testing at the U, that they don't do that for teens. My daughter was almost 17, and I asked to be referred to the PAUSE clinic, and he wrote down a number for therapy on a paper towel from the dispenser and sent me on my way. He said that the U of U and Primary Children's Hospital do not do dysautonomia testing, and they do not treat vascular compression syndromes, which is Nutcracker syndrome, MALS. And they think that if people have those surgeries, they don't get better, but they just have more and more complications. So Dr. Colby has created PC Cares, which is, he's trying to create like a Shriners type hospital for kids with dysautonomia and complex conditions. I don't think he takes patients, but eventually he will be. But the PAUSE clinic, it stands for Pain Autonomic Symptom Evaluation and Support. And one of my providers told me that what they're doing there is about 10 years behind. Like that's what they were doing 10 years ago at the Mayo Clinic. So, but I would have taken my daughter there had they offered a referral, because those type of pain coping skills and mental health skills and interdisciplinary treatment are amazing. And I wanted that for her. But I got anxiety, and here's a number to a therapist. So, and I'm a social worker who teaches people how to go to the doctor and talk to doctors. It was very sad. There's a lot of school accommodations that people can get. These are all resources like sitting with your feet up, access to water, missing school if you need to, doing online school, things like that. A lot of people ask, can someone with POTS recover? The short answer is yes. However, if someone has POTS and they recover and they overdo it or they get a virus, they could go back into the way they were before. So one of the things related to POTS, and we're going to take a break in just a minute, sorry, is hypermobility. Here's a video on hypermobility.
I am a zebra. Ehlers-Danlos syndromes, or EDS, consists of 13 heritable connective tissue disorders. Connective tissue makes up roughly 45% of your body, and connective tissue provides the support, protection, and the structure to your other body parts. Which means if you have faulty connective tissue, a lot of stuff can go wrong. The most common is hypermobile, seen in roughly 1 to every 3 to 5,000, whereas some of the other subtypes are seen in less than 1 in a million. While each characteristics of each of the different subtypes can vary, there are some things that are common for all of us. Things like joint hypermobility, skin fragility, joint pain, and just overall fatigue. Now, how it manifests in each individual person can vary greatly, even in between the same subtype, even in between the same family. The hypermobile subtype is the only one today that does not currently have a gene identified for it. I was in my late 30s before I was diagnosed, and it only even got on the radar of my physicians because my sister had been diagnosed after she was diagnosed and came to me saying, hey, I think we all have this. That's when a lot of these things started kind of clicking. And even then I went to my physicians like, I think I have this. And I was by some folks that, no, you can't, it's too rare. They were kind of scared to be the first one to say that this might be it. I pulled my surgical records previously, and there I found in the operating notes that previous surgeons had noticed that I was actually hypermobile in the surgery, in the operating room, and had to change the way that they positioned me in order to basically treat me like a hypermobile patient. They just never told me. So maybe they thought I knew. I don't know. This question is a bit triggering. How long? Too long. Putting a spotlight on these rare diseases hopefully means that when the next patient walks into your office and has some sort of unexplained issue, probably accompanied with
normal lab tests and results. Their physician will remember. Maybe for that patient, it'll mean being diagnosed in months instead of years.
To learn more, visit www.osmosis.org/.
So I'm wearing a zebra shirt today because people with hypermobility are known as zebras. The reason we're known as zebras is because doctors are taught that when you hear hooves, think of horses, not zebras. Medical care is based on probability and what's more likely to happen. And if you're like in that 10 to 15% of people that have these issues, then you're just crazy. You don't really have them. So that's a major problem. So people with hypermobility spectrum disorders have a higher prevalence of anxiety, depression, neurodevelopmental disorders, bipolar disorder, and suicidality. Connective tissue in the brain is also different, and they're now studying that and how that affects mental health, which is quite interesting. 42% of individuals with hypermobility present with psychiatric comorbidities, primarily anxiety and depression. And if EDS has a higher 7.4 times higher risk of autism spectrum disorder and a 5.6 times higher risk of ADHD and 3.4 times higher risk of depression compared to the general population. So we'll talk about that a little bit more, but here's just a graphic for you to look at. This is the Baton score, which kind of shows you what you have to do to be hypermobile. I do not have the full criteria for hypermobile Ehlers-Danlos syndrome. I have a hypermobility spectrum disorder. I have never been able to bend over and touch the floor. I've never been able to do the splits, but I do have like hypermobile fingers, and I can put like my hand down to there. My arms kind of do that, but not really. A lot of people are more hypermobile than me, much more. But look at how many problems I have because I have hypermobility. There's a huge healthcare burden if you're hypermobile, like 48 plus 33 spent 5+ hours weekly coordinating care. So that's like almost 85% of patients, 5 hours a week coordinating care. Average of 6.5 specialists a year. And all of them had out of pocket costs and Medi paid for specialist care not covered by insurance. So it is difficult to get care. Some states, some cities have really amazing care for dysautonomia and hypermobility. Utah is okay, but I have considered going out of state just to see like someone who has an interdisciplinary clinic that specializes in what I have. They did have a clinic here called Metrodora. They were trying to be a women's health clinic that treated all of these places, but they had problems with management and funding, so it shut down. This is mast cell activation syndrome. Almost ready.
MCAS can affect multiple parts of our body. Some of the common symptoms include our skin, which can result in hives, itching, and flushing, our gut, so abdominal pain, bloating, diarrhea, and sometimes constipation, our heart and circulation with rapid heart rate, dizziness, or fainting, our lungs, wheezing, shortness of breath, our neurologic system, headaches, brain fog, anxiety, difficulty sleeping. As you can see, MCAS is a multi-system disease. It can affect your entire body. And here's a crucial thing to remember. Every MCAS patient is unique. Your symptoms might look a little different from someone else's.
Okay, so they think that mast cell activation syndrome is actually the underlying driver of hypermobility. And there's something called the trifecta, which is hypermobility, POTS, and MCAS. These are some resources about MCAS. It is hard to get diagnosed with MCAS. You have to go to a special doctor that actually knows about it. And I have a list of those for you. Then there's MECSF. And we're going to take like a 5-minute break and come back.
Okay, so we will, let's see, it's about 11:15, 11:16.
Yeah,
If you
11:16.
want, I was just gonna say, there are about 3 questions in the Q&A, if that's something you want to look at, not necessarily answer during this break, but just, you know, if you want to look at them. Or...
Okay. I don't know if I know how to look at them. Oh, I found it.
Yeah. Actually, let's see. The bottom one is just about slides, so I can answer that one.
The diagnosis of
Just so everybody knows, we will be sending those slides out with the certificates. So I've had a couple of questions about that, but Ashley's going to get those to me and we'll be sending those out. So.
Okay, so I'm gonna go ahead and start. My watch says 11:16. We are on myalgic encephalitis and chronic fatigue syndrome, or MECSF. And here is another person talking about
The
MECSF.
diagnosis of chronic fatigue syndrome or myalgic encephalomyelitis, ME, to say it the short way, it's a criteria based on clinical symptoms. So it has to be fatigue, post-exertional fatigue with malaise, which are the flu-like symptoms. There has to be a sleeping problem. People have unrefreshed sleep. There may be pain all over the body, not necessarily with swelling and redness, but there's pain that migrates. There often can be autonomic dysfunction. Person has difficulty with their blood pressure, either going too low if they stand up, and they may have a tachycardia syndrome. Their heart may race if they stand up, and they might feel lightheaded. They may have abdominal problems with irritable bowel-like symptoms, and they also may have immune problems. They may get a lot of different viruses repeatedly, or they may be hypervigilant and they hardly get any infections at all.
This is NSU.
Okay, so in Utah, there is the Bateman Horn Center in Salt Lake City. They have amazing resources and an excellent YouTube channel. As far as I know, they're not taking patients. They maybe only take cash now. I'm not positive, but they do research. So sometimes if you go to their website, you can sign up for a research trial that could help. Here's a really good document by the Bateman Horn Center on diagnosing and treating MECSF. Part of their mission is to teach providers how to treat these disorders. And so, like, this is something that you can print off and take to your provider. This is their top resources. And another amazing website is the Work Well Foundation. And there's a fatigue severity scale, because this is not the same as I'm tired after work. Like, I used to be able to work, take care of my kids, do my laundry, take care of my lawn, exercise, and I was fine. Yeah, I was tired, but I could do things. So this is very different. This post-exertional malaise is the hallmark symptom of MECSF, and exercise can make it worse. And this is a really excellent video by Clayton Powers about the basics of post-exertional malaise. He's a physical therapist in Utah who helps people with all of these different things. Here is one person's experience with chronic fatigue, and PEM is what they call it, post-exertional malaise, or PEM.
I'd never felt anything like it before until I started experiencing it. It's not just I exercised and I'm tired or sore the next day. It's that my heart rate went up and I can't move. I had periods where I couldn't speak. Like, I just felt so entirely paralyzed by whatever sort of energy system in my body was failing. And it also comes with sensory overload. So any sound, any noise, any light feels painful. And it's the cognition again for me that's really terrifying, in that I was watching a movie with my partner and I couldn't follow anything. When I was, as somebody who writes for a living, it was really startling to me that I couldn't keep track of the characters, I couldn't keep track of the plot. And so really disproportionate bodily and cognitive and emotional reactions to what's going on. It's a really strong signal that there's something going on, and also that you probably should not keep pushing, because that's the thing that's triggering these reactions.
So I can't remember if I mentioned this, but exercise can make it worse. And there is a letter here explaining why and how. It is an energy production problem. It is not just not trying hard enough. So long COVID, I just want to mention that there are comorbidities with hypermobility. When people get long COVID, they get POTS, they get MCAS, and they get MECSF. So, and they're almost the same thing. If people were in the ICU with long COVID, it's very different than someone who has long COVID, that it's just impacting their ability and making them really tired and different. Neurodiversity. I don't know what's going on. Is it okay? Is it better now? Okay. Okay, so neurodiversity is, I think we mentioned that before, but adults with ADHD, autism, and tic disorders have elevated rates of joint hypermobility, 50% compared to the general population, which is 20%. So, also, there are links between being a highly sensitive person, having OCD, and PANS and PANDAS. I don't know if you know what PANS and PANDAS are, but this can happen if a child gets strep throat, and then after they have strep throat, they have symptoms of OCD. They have the symptoms of fatigue, brain fog, ADHD, impulsivity, and it's really hard to treat and very confusing for parents. So if someone has a severe infection like strep throat and then that happens, there is Beehive Medical Clinic. I think I forgot to put that on my list. It's Beehive Comprehensive Clinic. It's in Riverton, and they treat PANS and PANDAS. There are complex comorbidities. So the trifecta is POTS, hypermobility, and MCAS. And if you have the trifecta, you're more likely to have Nutcracker syndrome, which I had, or MALS, or MACS, SMAS. People with cranial cervical instability also sometimes that means that their neck isn't, like, the connective tissue around their neck makes them even more likely to pass out. So you might see people in wheelchairs tipped over, you might see people wearing neck braces. And what I notice is there's like this population of people, like, I don't know, 15 to 25 that has these symptoms earlier and worse. And there's more of those. And then there's a group of people my age, like 35 to 45, that maybe has one or two of these problems, but they're not as bad and they're not as hypermobile. And then there's like women in their 60s that have been gaslighting themselves for years that have Nutcracker syndrome, pelvic congestion syndrome, and POTS, but they were just told they're crazy, so they're not getting help. But there seem to be fewer of these women. But is that because they think they have fibromyalgia and chronic fatigue syndrome? That's what I was told I had. But because I had left-sided swelling, I kept pushing. This is a documentary. It's called Complicated. It's by the same producer, and I think this preview is important to watch.
Was always a really strong kid. Then puberty started.
He went from having fun, suddenly developed a very high fever, and that's when everything changed.
It was my dream to be a great figure skater. That moment that I arrived at the hospital, I just walked right into hell. They didn't believe that my seizures were real.
A lot of doctors thought that I was just a young girl who wanted to get out of high school.
Ehlers-Danlos syndrome is a genetic disorder. There's at least 13 different forms, some which are very serious.
EDS is like earthquakes. You can have a 1.2 or a 6.4.
I have pain in every part of my body. I have 16 screws from the top of my head to the bottom of my neck.
A lot of doctors feel like this just can't be real.
You have a perfect storm for a doctor to sit back and wonder. I've heard about this medical child abuse where parents and patients are sort of faking their illnesses. Could this be that?
And it became very clear that they were suspecting medical abuse.
Very quickly, these parents realized that the people they're dealing with are willing and able to take their sick child away. And it happens every day.
They say that we are doctor shopping, that I'm making up symptoms.
The proof against all the allegations, I can't see the end of it anymore.
All of my patients are scared to death that somebody's going to take their child away.
I believe that there are more people that have it. They easily can misdiagnose you.
Women are less likely to be believed.
They don't know what to do with these complicated cases.
Most of us have tried anything and everything to make ourselves better. I just want this to kill me already.
Where did I go wrong that she would be accused and I would be accused?
Um, so I think that shows like how complicated it is. One of the things that happened with my daughter is like I knew what it was. She was sick, but I let her hang out with her friends even if she couldn't go to school. I had her
Doesn't
drive
feel good, but it's not.
car
I touch
to
him and he feels
school.
normal now.
I drive. Let her drive the car to school. We live about a block away from the high school, and all my other kids were like, "Ah, why does she get to drive?" But I've heard stories of kids going to the doctors with their parents and they go to a neurologist, and the neurologist said, it's all in your head. You're not trying hard enough. Maybe if you gave your daughter more attention, she would stop acting like this. Um, so then that person stopped going to the doctor because she did not want any more attention and she did not want people to think that of her. She's now had surgery for nutcracker syndrome. She has POTS. She has craniocervical instability. It's it's complicated. And if a doctor tells parents that, they're going to push their kids. They're going to be mean to their kids about why is your homework not done? Why are you not failing your classes? So it's really important to understand these conditions and how to manage them. We're running a little behind, but we're going to get to that. So causes, genetics, hormones, infection or a virus, autoimmune disease, environmental triggers, poisons, pesticides, heavy metals. They say that we are kind of like the canary in the coal mine, and I'm not sure that you're aware of that analogy, but they would take canaries in coal mines, and if the canaries stopped singing, they knew that there was toxic gas. So we are reacting to environmental triggers, pesticides. I feel better in Idaho where the air is clean. So does my daughter. Mast cell activation syndrome, where you react to all of these chemicals and pesticides, your body kind of like becomes overwhelmed by them. Like I'm allergic to tape. And I had to have hand surgery because my stitches didn't dissolve last time I had hand surgery and caused all kinds of problems because apparently I'm allergic to stitches now too. I've had to have metal clips removed from my body because they cause allergic reactions. Um, like candles, anything with a fragrance is kind of a no-no because those are neurotoxins. Uh, so try getting your teenage daughter to stop using Bath and Body Works. We did find some very natural perfume that she liked. They say that lifestyle, physical activity, and diet and persistent stress and trauma can also affect you. So basically, like stress or trauma can turn on these things, and then how you manage it can make it worse or better. It's important to remember that this is biological, psychological, behavioral, and sociological. I think our society forgets a lot of the biological and sociological components of pain. Like people are not just catastrophizing. It is really hard when all of a sudden you can't do anything. I think most people would be catastrophizing. It's the wrong way. So these kinds of issues require interdisciplinary treatment. Metrodora could have been amazing, but they only took cash and they charged a lot. So I don't think people with disabilities really have a lot of money. So maybe that's why they had to shut down, but they're still doing research. But a dietitian, a mental health therapist, physical therapist, speech therapist, occupational therapist, and multiple medical providers like pain management, neurologists, primary care, cardiologists, allergists, immunologists, endocrinologists, and geneticists. So, yeah. Oh, Metrodora was in It's in West Valley, and it was going to be like one of a kind, the only place in the world that treated these hypermobile spectrum disorders. But I guess because patients are too complicated and how much time they have to spend with people, they started charging like a $1,200 or $2,200 fee to go there. And that's what the Bateman Horn Center does too. Um, I just think it's important to mention this, that you need, if you have any of these things or if your clients do, um, they need a good primary care doctor who listens, believes, refers, and advocates. You, if you don't have one of those, find a new one. And the ER and Instacare are not good places for answers. They're not like TV. And I don't know if you've ever seen the sign at Instacare, but it says if you have a chronic condition, this is not the place to manage it. You need to go to the doctor. Doctor appointments can be difficult. A lot of people get scared to go to the doctor because they've had so many difficult experiences going to the doctor. So you could bring someone to go with you, write things down, ask to record the appointment, and look at reviews, and ask about the providers on the Facebook groups. Ways to assess for referral as a mental health provider. Consider the comorbidities. Do they have migraines, headaches, GI problems, pain, fibromyalgia, joint flexibility, ADHD, autism? Is their depression and anxiety just not improving? It might not be depression or anxiety. So POTS questions to ask. Do you get dizzy when you stand up? Do you get dizzy when you stand for too long? Like what is standing in one place like for you? Like in a line at the grocery store or cooking? I don't go to the post office. If I do, I take my walker because standing in one place is the worst thing for me, especially if it's hot. Like, think about going to a barbecue. I'm not going to go walk around in the summertime and talk to people. That's kind of like a POTS attack waiting to happen. What is showering like for you? People with POTS will often notice that they feel like their chest hurts in the shower. They might be really tired after the shower. They have to get out of the shower and go lay down. They might notice their feet are red. The reason the shower is so bad is because it's hot. And when you're hot, your veins dilate, which makes your blood pooling worse, which makes your heart rate go up more. So if you're in the heat, does your heart rate ever get high? So if like someone's wearing a watch, have you ever seen your heart rate high? What was the highest it got? We'll talk about heart rate, normal numbers. Do you feel better when you sit down or lay down? Do you feel better at sea level? Going to sea level is not just because you're on vacation, it is because there is more oxygen, more pressure on your body, and oxygen decreases inflammation, which improves mast cell activation, and pressure helps you regulate your blood pressure if it's going too low when you stand up. And you can ask questions about post-exertional malaise. You can show them videos about post-exertional malaise and say, wow, like maybe you should go to the doctor for that. Family history. Does anybody in your family have this? Like my grandma definitely had chronic fatigue. She had depression, but I'm guessing she also had chronic fatigue too. Here are some informed referrals. The thing is I can give you all of these doctors' names, but if they're not on your insurance or they're not in your community, it can make it more difficult to go to them. So here are local Facebook support groups where you can go and you can like search providers. Some of them have a provider list. And so those are very helpful. There are also national and specialized groups. And so you can go to those groups for like a larger group of people than the one that's just for Utah. The renal nutcracker syndrome group and the CSF league groups were extremely helpful for me in navigating those problems. And then books, podcasts, websites, influencers, movies and documentaries. Great. That was wishful thinking. um, so mental health. Can providers push stereotypes, gaslight, give false promises about trauma therapy and mindfulness as a cure? Um, I think so. I definitely experienced that. And a lot of people like say if you heal your trauma, you'll heal your body, which isn't true if you have all of this stuff. It helps 100%, but it doesn't cure you. So depression is a comorbidity of chronic pain and illness, and it complicates treatment due to increased maladaptive behaviors. And I think therapists don't really understand how complicated it is and how much different your life is. Like when I am extremely disabled, my husband does the laundry, he does the dishes, he does everything, and I work 10 hours a week and survive. So it's very different than being who I was before. And we talk about often that we're the only ones that see that. We don't let other people see it, even our kids. Musing for Invisible Ones. So this is just a beautiful poem about this. It says, there was no funeral, no eulogy, no altar of memories, just a body still standing but dimmed. The lights didn't flicker, no one gasped. The world kept spinning like your life hadn't ended in 100 silent ways. You learned to mourn in grocery store aisles, in the soft betrayal of stairs, in the long negotiations with your own skin. Your grief is private, like shame, like hunger. People see your smile and call it progress. They see your makeup and say you look good, as if the dressing of a wound is the same as healing it. But they don't see the costs written in the margins, the planning it takes just to be upright, the solitude mistaken for independence, the friendships that wilted, and the quiet when you stopped saying yes. You've lost whole seasons to fear and to fatigue. You've buried dreams quietly like stray birds fallen from the nest, too small for ceremony, but too precious to forget. They don't see that you live in a haunted house of your own body, a place once familiar, now full of locked doors and strange noises in the night. And still you rise, not like a phoenix that's too clean, too mythic. You sprout like moss on stone, soft, persistent, growing even where light is rare. No one brings flowers for the invisible. So let this be your bouquet, words with weight, love with teeth, truth with tenderness. That was written by someone in the Utah hypermobility group, and I asked her if I could share it, and she said yes. And it always impacts people with these illnesses. It's a really good description of how it affects you. Anxiety, I think a lot of people think anxiety leads to pain behavior, but people are not trying to get attention for pain. They're actually trying to like hide it. They don't want you to see it. They're not thinking like, my pain is so bad, my life sucks so much. They're thinking, how long will this pain last? What is my future going to look like? Is the doctor going to be nice? Are people tired of me being sick? Can I handle these side effects? Do they believe me? So it definitely complicates anxiety. You have a lot more to worry about. And your body does not work the way it is supposed to. And you're using physical, cognitive, emotional, and orthostatic energy, or like that's what's going on. So you're sitting upright, you're holding a phone, you're speaking, actively listening, visually processing, maintaining blood pressure, heart rate, body temperature, respiration, filtering external and sensory noise, light, movement, odors, reacting, laughing. Cognitive, you're interpreting facial expressions, tone used, emotional, discerning moods and emotions of people, and orthostatic, time with feet on the floor, sitting and standing. I bet you've never thought of how these things affect you because you do not have a hard time being upright. but everything you do costs energy when you have chronic, the trifecta, we'll call it. A lot of people experience brain fog, forgetting things off of it and making frequent mistakes, being easily overwhelmed, inability to find words, slow to process thoughts, anxiety, or nervousness. So, if your brain isn't working and you're not used to your brain not working, that's a whole new thing that you have to figure out. Speech therapy for me was really good for that. Um, and then chronic illness masking. So forcing yourself to keep plans even when you feel awful, saying I'm fine when you're anything but. Minimizing your symptoms so you don't seem dramatic, powering through when you need rest, apologizing for needing help. All of these things lead to Little Miss pretends she doesn't have a chronic illness, then does too much, and then can't move from the sofa for 2 days. Dr. Bateman says that pacing is the most important thing you can do for your health. This is an excellent pacing series that people can watch to learn how to pace. This is the push crash cycle. You do too much, you have a flare, you rest, you're feeling better, you do too much, you flare, it just keeps going. So you have to learn to manage your energy, and you have to be willing to manage your energy, which means doing things that make you flare, that make your heart rate go up, that make you too tired. And a lot of people don't want to stop doing that. But if you want to get better instead of worse, that's what you have to do. This is a really good video on pacing. Here we go.
You have an energy budget for the day, like money in a bank. Some people have a lower budget and run out faster. The budget you start with can vary from day to day. If you overspend one day, it's like taking out a mortgage on the next day's energy with high interest. You might not feel the deficit today, but you could tomorrow. Things that energize, like breaks, spreading out your activities, and switching between activities help you regain your energy budget. Having a bad day on Thursday might be because you spent too much on Monday, Tuesday, and Wednesday. Would you be willing to change how you do things to accomplish more over time? Start by finding your baseline. Activities that you can do without much fatigue. Focus on activities you need to do versus want to do. Which activities can you say no to for now? Which activities can you break down into chunks? And can you switch activities or rest in between? Do some level of activity each day, but plan to stop before you feel fatigued. If you can only walk for 15 minutes before fatigue sets in, walk for 10 minutes, then rest or switch to something easier. Use time rather than fatigue to guide how you spend your energy. Spend at least a week or two at your baseline to let your body adapt. Then increase the energy you spend in very small chunks. Give your body 3 to 5 days to adapt to any increase and monitor your symptoms. It may take a while to figure out if you can increase activity and by how much. To recap, start at your baseline and spend time here. Schedule energizers, breaks, or switching between activities. Stop before you have an increase in symptoms. And slowly spend more and see how you adapt.
Okay, so that is pacing. The WorkWell Foundation has information about how pacing works and why it is important to pace. And basically, the better you pace and not go into a flare, the more likely your energy envelope will increase. And maybe your baseline was here, but the more you stay within your limits, your baseline moves up here. And so it's not good for you to like be sick, rest, and feel good and do too much and then be back down here. You have to pace and watch your heart rate and your activity, your sleep, your stress. So you stay more like you're going to have dips, but you're not crashing. And the less you crash, the more stable your energy will be, and the more able you will be to recover, or at least have a better quality of life. You'll have less brain fog, less tachycardia. You can do more things with your family and friends. But in my POTS group, everyone hates it when I talk about pacing. They're like, Ashley, you're always talking about pacing. We joke about it, but um, so this is pacing by the numbers. It's a formula to help you know what number you shouldn't go over. And this is for people with chronic fatigue syndrome. And so basically, like my number is 103 if I'm having a good day, but my watch will tell me at 98 I need to sit down if I'm having a bad day. Um, it's really important if someone has a POTS attack and their heart rate goes over that number or is very high, if they're able to sit down and get their heart rate to go down, then it is not as likely to dip into their energy envelope or to cause a flare. And it's really hard for people to like recognize their symptoms because they think they're anxiety or they're just like, I don't know what's wrong with my body. It's always a mess. And so this is a list of like symptoms that people have. I did this with my POTS group. We made lists of things that everybody has. But basically, if you notice what your first symptom is and you sit down before you've been standing for 2 minutes, then these immediate symptoms like feeling dizzy, feeling like you're going to pass out, getting sweaty, turning red, your chest hurts, maybe your bladder all of a sudden starts to act weird, those are going to stop and you're not going to create short-term symptoms, which are muscle and joint pain, brain fog, headaches, sleep disturbance, fatigue, bloating, hoarse voice, which I have. Long-term symptoms include weakness, decreased function, and rolling post-exertional malaise. So it is important to like know your symptoms, and the less you push yourself, the better you will be. It's hard to stop pushing yourself, and often people don't know the difference between a flare and what their baseline is. Um, a flare is when everything is worse, and your baseline is when you're feeling pretty good. I have a really hard time getting people to understand normal versus abnormal heart rates. So, low intensity exercise like walking at a brisk pace, your heart rate would be 110 to 122 if you were a 27-year-old woman on average. Moderate intensity exercise, which is cycling, jogging, hiking up a steep hill, is what your heart rate would be. 123 to 147 is what your heart rate would be. And so, like when we started, I was potsy for some reason. My heart rate was 116. I was not briskly walking. I was sitting on the couch after getting up to fill my water bottle. I'm overly tired today. And so that will make my heart rate go up. But a lot of people with POTS will constantly have a heart rate of 123, 147, 163. And there's like, there's nothing I can do. You need to sit down. You cannot just keep going unless you want to make yourself sicker. And when you tell people, like, well, when a heart of a 27-year-old person is at 123 to 127 and are hiking, cycling, or jogging, that's why you're so tired. It's because your body feels like you're doing those things. High intensity is a spin class or running a race. And many people with POTS, especially if they go outside, will get to 149 to 184 just because they go and get in their car and it's too hot. So that is like running a race or doing a spin class. So that's why people are so tired. Stats to check are heart rate. If it's too high, you need to sit down, hum, breathe, blink, put an ice pack here. Heart rate variability, which a lot of wearables measure, it needs to be in the normal range. Mine just gives me a normal range. If it's too high or too low, it can indicate overdoing it or illness. And then your resting heart rate, if it's 10 beats above or below what the average is, you're more likely to have a flare or an energy problem, more brain fog. So these are different wearables you can use. My favorite is a Garmin watch. I use a long COVID pacing app made by a man in Germany whose wife has long COVID, and it has been incredibly helpful. These are gadgets and mobility aids like a cooling fan, a walker, a vibration plate. It's a way to move and get your blood flowing. And it sometimes makes your heart rate go up, but not always. It depends on the person. Again, everyone with POTS is different. I find that people are more likely to use a shower stool if it looks like this instead of one of those ugly plastic shower stools that you see. After my CSF leak, I was working in a yoga chair. Um, these are glasses that you can use. If you put them on, it makes you see the TV while you're laying down flat. So if you have a really bad headache forever, sometimes I carry this in my purse. When it's too hot, I just spray myself. And then this is like an oxygen can. So if you feel like you're not getting oxygen, you just give yourself oxygen. That helps like decrease my flares. These are energy saving tips. Very helpful to get clients to think of doing things differently. Occupational therapy can also be good for that. I do not know an occupational therapist that specializes in that, but in those pacing videos, there is an occupational therapist involved. This is spoon theory. What spoon theory means is that let's say that like everybody has 10 spoons at the beginning of the day, and it might take you like a half a spoon to shower, but it might take me 5 spoons to shower. So it helps people understand that our energy isn't the same, and how many spoons it takes me is different than the amount of spoons it takes you. And I've even seen people that have like, they made these like cute spoon things to hang on their wall so their family knows how much energy they have. And then like nervous system regulation is huge. Somatic therapy, yoga nidra, qigong, EFT tapping, vagus nerve exercises. These are some really cool videos. If you don't know about slow blinking, taking charge of your blinking really calms down your nervous system. It's very interesting. It might even make you sigh, yawn, or swallow, which is a sign that it is regulating your vagus or stimulating your vagus nerve. Nature and sea level are also good ways to help. Your body will feel more regulated at sea level. It's not just because you're on vacation. These are sensory and environmental stimuli that you can take care of if you're in a flare. Down here is the MECSF Crash Survival Guide by the Bateman Horn Center. They are amazing. Different types of rest. This is a pot circle of control. So helping people feel like they are in control of some things can be extremely helpful. Because they feel like they have absolutely no control of anything because of their illness. Suicidality is increased in people with illness and chronic pain. And again, remember, if someone has PTSD and chronic pain, it is a greater risk for suicidality. And so is more limited functioning. If you are unable to do things, you are more likely to have suicidal thoughts, especially if you're younger. Trauma is really important to think about. It can cause you to be in fight or flight mode. And chronic pain is a chronic trauma, like domestic abuse or violence. Chronic pain is its own trauma. To begin to understand how chronic pain impacts a human, you need to understand how the nervous system responds to ongoing, inescapable stress. Managing pain and managing trauma have to go hand in hand to manage either. So, trauma treatment, unresolved trauma and chronic pain need to be considered in treatment. Patient must be stable to do trauma work, EMDR, brain spotting, somatic therapy, yoga. Trauma treatment can cause a flare, so you need to be aware of that and tell your clients about it and be gentle. Eating disorders is another comorbidity, and people with POTS, MALS, SMAS, MCAS, or Nutcracker syndrome can present like eating disorders. If you go to my webpage, it's believepain.com/malls, there's probably like 15 articles about people that were diagnosed with an eating disorder, but they actually had MALS. This is an MCAS and eating disorder resource. It's by the Gaudiani Clinic. I don't know how you say that, but she wrote the book Sick Enough about eating disorders. And in my training at Center for Change, I learned that unless someone has an allergy that shows up on blood work, they need to eat that food. But she says that this is not true for MCAS patients and it needs to be considered an eating disorder treatment. And she has an excellent list of resources. I help other people's patients get diagnosed with these things because they're like, I think my client doesn't have an eating disorder. So, health at every size and weight inclusivity is incredibly important. Health at every size means that we're focusing on sleep, exercise, mental health, trauma treatment. Do you hang out with friends? We're not saying lose weight because losing weight doesn't work and it can actually make people worse.
Bias.
So, examples of diet culture, examples of the harm of diet culture, and 95% of diets don't work. And sometimes when people go on a diet and they lose weight, they are more likely to gain it back and then some because of the way our bodies work. This is about pain. Pain gate openers are stress, anxiety, depression, catastrophizing. Pain gate closers are emotional regulation, relaxation, social kindness. So if you can help your clients understand this, that like thinking negative things about your pain makes your pain worse. But if you can do these other things instead, that is very helpful. These are some pain resources that are very helpful. A chronic pain scale, exercise. This is just a little bit about exercise, how to go about it. None of these things in here are like you tell your clients to do them. They go to physical therapy, they ask their physical therapist, and then they do it. They don't start drinking salt on their own. They go to their doctor, they ask their doctor about drinking salt. If you have intracranial hypertension and you start drinking salt, that can make you very, very sick. So therapy modalities, body neutrality, body neutral affirmations. You can't be mean to your body if you have all of these other things going on with your body. So this is really important in treatment. These are some resources about medical issues, food and body image, grief, disenfranchised grief. And then there's a book, 100 Ways to Heal Your Chronic Illness Grief, radical acceptance. Like radical acceptance means that you aren't constantly pushing yourself into a hole. And pain plus a lack of acceptance equals suffering. Self-compassion, disability guilt is huge. That doesn't help. It does not help to say, I shouldn't be laying in bed. I need to get out of bed. I shouldn't be resting. I need to be doing this. Self-validation, you have to learn to validate yourself. Self-care and joy. People who are stressed and have a chronic illness, they say need twice as much joy. And people who have a chronic illness feel like they're doing self-care all the time, but resting and taking care of your illness, sure, that's self-care, but you need to do something a little bit more fun and refreshing. Mindfulness-based orientation, body scan resources, CBT, DBT. This is a really cool presentation on DBT and chronic pain ACT. This is a really great article on cognitive and psychological issues in POTS. And I'm done. There. Sorry.
That's a lot. There's a lot there, and I'm so glad that we've recorded this because people can go back and grab those, and look
Yeah.
at that. So
Yeah.
that's amazing that will be this recording will be uploaded to our YouTube channel. So you want to watch for that. Thank you, Ashley. This has been amazing. I feel like I'm just overflowing with, so much info and so many more questions now than when I came into it, but that's a good thing. We do have some questions. If you've got some time, I'm going to just
I do. Sorry that.
No, that's fine. I am just going to remind everybody that if you need to go, then please grab that link that is in the chat so that you can fill out that evaluation and get your CEUs. I will be sending Ashley's slides along with those certificates. So if you want the slides, make sure that you're filling out the evaluation or, letting me know if for some reason you're not filling that out, just that you want those slides. So thank you for being here. We hope you're with us next month. And if you can stay on, we're going to do some questions right now. So let me get into the Q&A. And I know there were also just a couple of things in the chat, but I'll go back to that. Let's see. I know that somebody was asking if you have any statistics for chronic pain and CPTSD, complex PTSD. I don't know if you know anything about, statistics of those two together.
I talked about that in there, and if you
Yeah,
have
a little bit. Yeah.
chronic pain and PTSD, or I'm guessing like complex PTSD also fits into that group. It does make you more likely to be suicidal, more likely to have an opioid disorder, more likely to have maladaptive coping disorders. That's why it's important to treat trauma and notice that chronic illness can also be a trauma.
Right. That's what I was thinking as well when I read it, and we see that correlation quite a bit.
Yeah.
Somebody asked in the chat, how do you get a diagnosis for orthostatic hypotension disorder?
That would be the tilt table test.
Okay.
And it's the same as getting a diagnosis for POTS. And what your body does during the tilt table test will determine whether you have orthostatic hypotension or POTS. So,
Okay. Awesome.
Yeah.
Let's see. First, a compliment. Wow, you've taught us so much today. I feel as though there is no way I can remember to keep an awareness of these types of chronic disease. She's asking for websites, and maybe that's what you've already given. Just a couple of websites that can help them refer a client, to that decision, testing. So some of the things that you've given us, I think, would be effective for that, just being able to give them those resources.
Definitely. Giving them resources, referring them to the Facebook groups.
Yeah.
One of the studies I was reading, it said that like 85% of people are getting their health information online. And it is not bad to know what is going on with your body or to understand your body.
Yeah.
And it said that only like 5% of people aren't going to the internet for advice. So all of the information that I shared is for clients, except for maybe like the DBT presentation. But I mean, that could be helpful too, because they could understand those connections. My website is very helpful. I shared that. It's believepain.com. It's not completely finished, but the POTS page is finished, and the Nutcracker syndrome page is finished, and the MALS page is finished. Dysautonomia International, the Ehlers-Danlos Society, and I have like a website page. Those are helpful. And the Bateman Horn Center is incredibly helpful. Their website has been one of the most helpful things for me as a clinician and a patient.
It's just amazing to see so many resources. I didn't even, I didn't know that was out there, It's wonderful what you've collected. That's so great. We did have somebody that was asking about the videos and how they could find the videos that you used. Is
Um,
that something that we could add to the handouts? I don't know, or what your thoughts on
yeah.
this?
So in the presentation that you'll share, the links to the videos
Okay, I did
are
see that on one of them. Yeah.
okay under the videos, and so you should be able to
I can go
just
back.
get it off of there. Yeah.
Okay. Let's see what else we have. Is hypermobility the same as contortion, or are contortionists on a different level?
I I don't know if it's like the same, but I would think that
Yeah.
like contortionists probably have hypermobility. Like that's one of the questions on the hypermobility scale. Like, were you doing weird things with your body, showing people that like you could do this or that or
Yeah,
whatever?
yeah.
And so if you're able to do those things, yes, probably hypermobile. You can look at that Baton score. You can go to a physical therapist after that if you're worried. But once in the airport, I was using a wheelchair to get from place to place, and the person pushing me was hypermobile, and somehow it came up. And he's way more hypermobile than I've ever been, and he doesn't have any health
Yeah.
problem.
So it
So
doesn't mean that if you're hypermobile, it doesn't mean that you have POTS or you have any of these conditions. It's just could be.
right,
Yeah.
right.
Awesome. Okay. Um, I think at this point, I'm not, let me see. Oh, somebody just put something in the chat really fast. Okay. If you have symptoms of POTS, ME, Ehlers, Daniel syndrome, HSD, and a few others, which doctor or clinic would you recommend going to first?
I would recommend going to your primary care doctor and asking for a tilt table test. And on that diagnosis page, there's different places where you can get a tilt table test, so you don't have to wait 2 years to get into the University of Utah. Or I would do the at home tilt table test and see. And when I would do that because that's the fastest way to get a diagnosis. And taking care of like your orthostatic hypotension is important, and learning ways to manage it. But I think the clinic that they could get into fastest is Dr. Paulson's clinic. Dr. Paulson probably takes several months to get into, but Brian Pontius or Kelsey Bettis would also be able to help them. I
Which you
will
look good
say,
on, yeah.
and those are in the provider list.
Right.
Sometimes when you go to the provider, they're like they don't teach the things that I teach because they don't have time, and it
Yeah.
is kind of like you have to teach yourself or find someone who knows how to do it, like a coach.
Yeah. Advocating for yourself. Yeah. We all need to learn how to do that better, don't we?
Yeah.
And then just a quick question. Somebody was asking which illness specifically was it that caused the left side swelling that you talked about?
I was Nutcracker syndrome.
Okay, that's what I was thinking, and I didn't want to say it wrong. So
Yeah, and the way it works is like if you have vascular compressions, apparently you're supposed to treat the top one first. But if you have Nutcracker syndrome and Malls is technically higher on your body than Nutcracker syndrome. But they said to treat whichever one affected me the worst. So I had an auto transplant. But sometimes if you don't treat them in the right order, like
yeah.
May Thurner syndrome is also something that made my left leg swollen. And that's why I got the stent. But it made everything worse because I had a compression higher up. And so it's very complicated to get.
Right. It's
Yeah.
something you really want to make sure you are working with, someone who knows what they're doing and not just guessing that, oh, well, let's do this or let's do that. Let's try this. Yeah.
And Dr. Paulson's clinic is really good. And Chris Harper is also like a phenomenal physical therapist who knows about all things hypermobility, including CSF leaks and cranial cervical instability and vascular compressions.
Right. This is amazing because I think with everybody else, as I'm hearing this and looking at the symptoms, I'm thinking about people, it's like, whoa, I think I need to give them this information, and that's what we're hoping for, is just bringing awareness to something that so many people don't know about. They don't even realize that could be what's going on. And so I'm so appreciative of you bringing all of this knowledge to us, because I think it's so important.
Yeah, you're welcome. And
Thank you.
I will say that, like, with my family at least, even though it's genetic and even though I see my family having symptoms that I have, they don't want to hear about it.
Yeah.
They think it's depression or anxiety, or just
Mhm.
they're not trying hard enough. So it's also like interesting to share this information. It kind of,
Yeah,
you have to do it in the right way, right?
exactly. Exactly. I see that. Yeah, that makes sense. Well, thank you again, Ashley. This has been amazing, and you've given people so much good information. And I wanted, people were asking about the recording, and just, we do put our recordings on our YouTube channel. If you're looking for the link to that, I mean, you can just Google it, the Children's Justice Center, but if you want the specific link to our YouTube channel, it is in the guidelines, the training guidelines that I attach to every month's flyer email. So you should be able to just go in there. If you don't already have that saved, just go into one of your last emails and open that up, and it's down at the bottom under recordings, and it has that link. And there is Ashley's information. So awesome. Thank you again. We really, really appreciate it.
You're welcome.
Yeah.
My comic is kind of funny. It's Bob Ross, and he says, "Down here, let's put a happy little posse."
Oh, I love that.
I
Oh,
went to Lake
that's great.
Tahoe, and I have a picture of me doing that in the mountains.
That's great.
Yeah.
That's an amazing picture. I love that.
Makes
That's
me
perfect. So good way to end it. All right. Well, I will be in touch with you. For the rest of you who might still be on, we will leave this open just for a little bit longer. Make sure you get that link and get your evaluations put in. Make sure it goes in before the end of Friday so that you can get all of that information. Thank you. We hope you can make it next month, and have a great day.
Thank you.